This is Dr. Hancock. Welcome to Topic 3, Microeconomics in the Healthcare Organization. The learner outcomes are listed in your syllabus and in Canvas. Your assigned reading for this topic is Chapter 3 of the Legere and Dunham-Taylor textbook and Chapters 1 and 8 in the Baker, and Dworkin textbook. Don't worry if you don't have both of these books. Just read the required textbook that you have and the articles and links I've posted on Canvas. That will be enough to allow you to achieve the outcomes. By the end of this topic, you're going to examine market forces affecting the hospital and other healthcare organizations. You'll be able to differentiate between for-profit and non-profit organizations, and you'll discuss financial consequences of specific policy decisions, such as staffing ratios and electronic health records. It will be helpful to review the different types of healthcare organizations before you begin. While hospitals are the classic example of a healthcare organization, many other organizational types exist. HCOs can be classified in different ways. Length of stay, type of service, or ownership structure are some that are commonly used. Some HCOs only offer short-term care, which is usually defined as less than 24 hours, while others specialize in long-term care, extending past 30 days and sometimes even for years. A traditional acute care setting is what most of us think of as a typical hospital. HCOs can also be categorized by type of service. One categorization is it a general or a specialty facility? Most hospitals offer general medical and surgical services, but there are some that specialize in a specific type of care. Examples of those would be a women's care hospital, children's hospital, a heart hospital, or a facility that only does weight loss surgeries. There's many examples of specialty HCOs these days. You can also categorize a facility by is it a community healthcare organization or a tertiary organization. Community hospitals are defined in different ways by different people. Truven Health Analytics, for example, divides hospitals into 5 comparison groups when forming its top 100 hospitals list. The groups they use are major teaching hospitals, large community hospitals, medium community hospitals, and small community hospitals. The broader definition of what a community hospital is goes beyond the bed size and teaching status and into various factors like where is it located, what's the governance structure, what's the role it plays in a town's economy, and the role it plays in increasing care access, among others. We often think of community hospitals as being in smaller towns, but that's not necessarily true. Urban areas can also have locally owned and run HCOs that serve their communities. Tertiary healthcare centers are nearly always found in large urban areas. It is an HCO that provides specialized consultative care, usually on referral from primary or secondary medical care personnel, by specialists who work in a center that has personnel and facilities for special investigation and treatment. In Mississippi, for example, the University of Mississippi Medical Center is an example of a tertiary care center, whereas a hospital like Ocean Springs is an example of a community HCO. Some HCOs only provide at-home care, while others only offer ambulatory or outpatient services. The ownership structure of HCOs can vary too. A public HCO is owned or operated by a government or a government agency, like the VA system, for example. Private HCOs can be for-profit or not-for-profit, otherwise known as charitable. A for-profit HCO may be owned by a single individual, a small group, or it can be a big publicly traded company with shareholders and a board of directors. Most physician practices and long-term care facilities are for-profit, and some hospitals are too, such as those owned by HCA or Merit. Many organizations are nonprofit. About 2/3 of hospitals fall into the nonprofit category. Nonprofits are mostly funded by charity, religion, or research and educational funds. The unique thing about nonprofit hospitals is that they do not have to pay federal income tax or state and local property taxes, but in return they're supposed to benefit the community. I posted an interesting article for you from Forbes magazine about just how profitable some of our nonprofit hospitals really are. As you'll see, the terms for-profit and not-for-profit apply to the ownership structure of the organization. But all HCOs want to have revenues that exceed expenses, which is sometimes called profit or even a positive margin. There are a few other specific types of organizations that I want you to understand. One is what's known as an academic medical center or a teaching center. This is a combination of a hospital and other healthcare services with some type of health professional school, usually, but not always, a medical school. A rural healthcare organization is one that serves people outside of city and urban areas. Usually rural hospitals are smaller in size and have modest assets and financial reserves, and they frequently serve a higher percentage of Medicare patients. Rural hospitals disproportionately rely on government payments, and that puts them at risk when government programs like Medicare and Medicaid change and cut their reimbursement rates or move to other payment options. Safety net providers are another important category. The healthcare safety net comprises hospitals and other providers that organize and deliver a significant level of health care and other health-related services to patients who have no insurance or Medicaid. These are often referred to as the providers of last resort. Safety net hospitals have historically assumed a major role in the provision of comprehensive services to medically and socially vulnerable populations. Safety net hospitals are about 25% of all hospitals, but they account for about 1/3 of all inpatient stays, and about half of all stays paid for by Medicaid or by uninsured patients. They also account for about 43% of all mental health stays. Another interesting thing to note about safety net providers is that patients are more likely to be admitted through an emergency department than by a direct provider referral. Now that you understand a little more about the types of healthcare organizations that are out there, we'll look at what are the issues that concern these firms. What are the microeconomic or market forces on healthcare organizations? The next article I shared on Canvas is entitled "The 10 Most Concerning Issues for Hospital CEOs for the Year 2017. You'll see on that list that there are a number of market forces that are creating pressure on all healthcare organizations, especially hospitals. 4 that I want you to focus on for our purposes are the impact of regulations, competition, the profit motive, and quality of care issues. It's interesting. Although our healthcare system is among the most market-oriented in the world, here in the United States, it is also the most heavily regulated sector of the U.S. economy. This will not be a surprise to you if you're working in a hospital or other healthcare organization. Regulations are one of the many reasons why we spend so much as a society, about 17 to 18% of our GDP, on healthcare. On this slide, you see just some examples of the various regulations and regulatory agencies that drive up our healthcare costs. For example, the Centers for Medicare and Medicaid often have utilization reviews to determine whether or not appropriate care was delivered. The Office of Safety and Health Administration, OSHA, inspects our facilities for workplace safety. We have accreditation surveys from the Joint Commission and other agencies. Every single state has its own boards of nursing, medicine, pharmacy, respiratory therapy, physical therapy, and some others. And of course, the cost of managing those agencies and the licensing requirements feeds into what we spend on healthcare. There's also things like the National Practitioner Data Bank, which keeps information on healthcare practitioners. We have limits on how many hours that employees can work, and we also have fraud and abuse protections built into the system. All these costs of staying in compliance with legislation and regulations substantially add to our overall healthcare spending, and they also put a lot of financial pressure on healthcare organizations. Competition is another market force, which is a huge impact on particularly some healthcare organizations. In theory, competition benefits consumers because it helps contain costs, improve quality, and encourage innovation. However, the structural and regulatory factors I just talked about have stifled competition. It's very hard, for example, for a new healthcare organization to form because of essentially all the regulatory hoops that it has to go through in order to become accredited and have licensed professionals. I'd like you to read the Brookings report that I posted on Canvas. It's called Making Healthcare Markets Work, Competition Policy for Healthcare. This is a really insightful report because it's a group of experts who've taken a look at our healthcare system and made specific recommendations for how we could actually improve competition in healthcare. In some ways by getting rid of regulations, so we could encourage innovation and hopefully cut costs too. It's not necessary that you read every single line of every page in the report, but I think the report will give you a lot of insight into what we could do to make healthcare markets more free and more efficient and more competitive. Regardless of the ownership structure of a healthcare organization, all organizations, as I've said, need to make money, which is often called the profit motive. The point I would like to make here is that a hospital or another healthcare organization exists to satisfy the needs of its various stakeholders. Some people believe that healthcare organizations only exist to serve patients or consumers. That's not entirely true. There's other reasons. They serve their communities at large. They provide training for different health professionals. They provide employment in communities. So a hospital really exists to satisfy the needs of all of its various stakeholders, not just the patient. So there's a couple of myths here. Like most of us work in nonprofits because, like I said, 2/3 of hospitals are nonprofit. So some people believe that if we are a nonprofit entity, we don't have profit. Not necessarily true. Another common myth is that we're here to provide the highest possible care. Also not exactly true. Healthcare organizations are not really in the business of providing the best care possible. Instead, they're in the business of providing a quality of care at a certain acceptable level. And the acceptable level of quality has to be driven by the cost of providing that care. So it's kind of a seesaw, if you will. Yes, we want to have good quality outcomes, but we can't go broke providing those. We have to control the cost and justify the quality of care we can provide. To compete on a quality of care basis, hospitals must report measurable aspects of quality of care, presumably at an acceptable level, to various governmental and non-governmental sources. The Centers for Medicare and Medicaid Service is one of the biggest payers in healthcare, and CMS has been moving towards something called value-based programs. Value-based programs reward healthcare providers with incentive payments for the quality of care they give to people with Medicare. These programs are part of the larger quality strategy to reform how healthcare is delivered and paid for. Value-based programs are important because they're moving toward paying providers based on quality and not quantity of healthcare service. This is putting an increased pressure to perform on healthcare organizations. We're also beginning to see the comparison shopping among consumers for quality. I don't know if you've looked at it, but there are websites now where you can compare hospitals or you can compare healthcare providers like hospitalcompare.gov and organizations like Leapfrog and even Consumer Reports. They rate hospitals, healthcare services, and providers on certain key metrics. Interestingly, consumers are starting to share reviews with each other now as well, using services like Yelp and Google. Try it. Go online and Google your primary care physician. See what the results show. You'll probably find consumer reviews, and in fact, you can post some of your own if you want to. The final article that I posted for you in this week's assigned readings on Canvas is an exploration of the business case for electronic health records. It'll help you understand the potential costs and benefits of a major information system implementation project. What you'll see is that electronic health records are considered essential today to the quality and efficiency of our system. These EHRs have major costs for the hospital, but they also can provide benefits for the hospital and patients. So you can see some case studies and learn a little bit more about how the costs have essentially paid off over the long run for organizations that have adopted EHR systems. Your discussion assignment this week is going to focus on the business case of nurse staffing ratios. HCOs frequently cut staffing to manage costs, but does it work to improve financial performance? You'll do some investigation on your own and then report your findings in Topic 3 discussion. Topic 3 is going to provide you with insight into the microeconomics of healthcare organizations. Please read the textbook and the articles I've posted in Canvas. There are no learning activities this week, but you do have 2 assignments to complete, including a discussion about nurse staffing ratios and their financial implications, and then a practice exercise to calculate break-even on a service. Let me know if you have any questions, and good luck!